Welcome back to the Deep Dive. Today, we are standing at the edge of a battlefield. For decades, the war on cancer was really fought with. With blunt instruments, we were using the medical equivalent of carpet bombing.
That is a pretty evocative, if terrifying, image to start with, but it's also historically very accurate.
It feels accurate, doesn't it?
Mm-hmm.
Traditional chemotherapy, the stuff we see in movies, the hair loss, the nausea, the bone marrow suppression, it's just so indiscriminate. It kills the enemy, sure, but it decimates the civilization around it.
It attacks life itself, or at least anything that's trying to grow quickly.
Exactly. But today, we're talking about the shift to the sniper rifle.
Yeah.
This is the era of targeted cancer therapies.
It really is a fundamental shift in, I'd say, both physics and philosophy. We're moving from this old world of killing anything that moves fast to the new world of identifying the specific molecular gears that are broken and, well, jamming them with a very precise wrench.
It's the difference between a sledgehammer and a lockpick.
That's a perfect way to put it.
And to navigate this massive shift, we're pulling from two absolute heavyweights. We have the clinical scaffolding from Katzung's chapter on cancer chemotherapy, which gives us the history and the grand strategy.
And then we're welding that to the intense molecular detail of Goodman and Gilman's chapter, Pathway-Targeted Therapies.
That's the mission today, right? To synthesize Katzung's how do we treat the patient with Goodman and Gilman's how do we design the molecule.
Exactly. One gives us the map of the body, and the other gives us the blueprint of the cell itself.
So here's the flight plan for today. We've got four main sectors to clear. First, we're going to look at this idea of driver dependence, why a tumor can become, addicted to a single signal. Second, the arsenal. We're going to break down the MABs versus the IBs.
Which I know it sounds like a Dr. Seuss book, but it is probably the most important distinction in modern pharmacology.
It really is. Third, the environment. So starving the tumor of blood and unleashing the patient's own immune system. And then finally, the trap.
The inevitable trap.
Why this incredible precision can actually create resistance and why we haven't, cured cancer yet.
It's a dense landscape. And I think I should add the disclaimer right up front here. This is a conceptual math. We are synthesizing very complex texts. We are not a substitute for the textbooks.
Absolutely.
You still need to open Goodman and Gilman to see the crystal structures and Katzung for the protocols. We're here to give you the framework so all those details have a place to stick.
Okay, let's get into it, the context. Before we can really appreciate the sniper rifle, we have to understand why we used the carpet bomb for so long. In Katzung, they talk about the log kill hypothesis. This feels like the foundational math of that old world.
It is, and honestly, it's where a lot of students get a bit tripped up because it just sounds like, forestry jargon, log kill.
Yeah.
But it actually comes from a very specific place, the L1210 leukemia model in mice.
Okay, so walk me through that. The L1210 model. Why do we care so much about a mouse with leukemia?
Because this specific mouse model gave us the math of destruction. In this model, the leukemia cells grow incredibly fast. The growth fraction, so the percentage of cells that are currently dividing, is basically 100%.
Wow. So they're all sprinting all the time.
All the time. So it's a worst-case scenario for the poor mouse, but it's a best-case scenario for studying chemotherapy.
Because traditional chemo targets division itself.
Exactly. It targets DNA synthesis or mitosis. So if 100% of your cells are dividing, the drug can, at least in theory, hit 100% of the cells.
And this is where the log part of log kill comes in.
That's it. The hypothesis states that a given dose of chemotherapy kills a constant fraction of cells, not a constant number.
Okay, hang on. Let's break that down because that's a really important distinction. If I have a tumor with, say, 1 billion cells, and I give a dose of drug X.
Let's say drug X has a 3-log kill potential, so that means it kills 99.9% of the cells it encounters.
That sounds amazing. 99.9% is an A+ on any test I've ever taken.
In school, yes. In oncology, it is a massive, massive problem. If you start with 10 to the power of 10 cells, that's 10 billion cells, which is roughly a small perceptible tumor, and you kill 99.9%, you've knocked it down by 3 logs. You go from 10 to the 10 down to 10 to the 7.
So I still have 10 million cancer cells left in my body.
Precisely. And those 10 million cells are still cancer. They're still aggressive, and they will grow back. This is the fundamental reason you can never, ever cure cancer with a single dose of traditional chemotherapy.
You just can't hit 0 with one shot.
You can't.
And this explains the cycles we always hear about. You hit them, the number drops, you wait. But why do we wait? What's the waiting period for?
We wait for the patient to survive the treatment. Remember, we are carpet bombing. We've hit the bone marrow, the gut lining, the hair follicles. We have to give the normal, healthy cells time to recover.
So it's a gamble.
It is a terrifying gamble. The bet is that your normal cells recover faster than the tumor cells do.
A war of attrition. You pulse the drug, you drop the tumor count, you wait for your neutrophils to come back up, and then you pulse it again.
And you just keep doing that, hopefully driving the number down below 10 to the 0, which effectively means 0 cells left. But Katsung points out a major flaw in this model when we try to apply it to humans.
Right. Real humans aren't mice with L1210 leukemia.
Exactly. Most human cancers are solid tumors. Lung, breast, colon. And they don't follow that neat exponential growth forever. They follow something called the Gompertzian model.
Gompertzian. That sounds like a sci-fi villain from the 50s.
It does. It was Benjamin Gompertz, a 19th century mathematician, and he realized that populations and tumors are populations of cells. They grow fast at first, but then they plateau. The doubling time gets longer and longer as the mass gets bigger.
Why does that happen? Is it just getting too crowded?
It's a resource issue. It's basic logistics. A tiny tumor has plenty of blood and oxygen, but a massive tumor, it literally outgrows its supply lines. The cells in the middle start to starve.
So they stop dividing.
They stop dividing. They enter the G0 phase, the resting phase of the cell cycle.
And if they're resting?
The chemo floats right past them. It's invisible to the drug. Remember, traditional chemo targets dividing cells. If a cell is dormant, it's safe. It's like a thief standing perfectly still so the motion detector doesn't see him.
That is a terrifying thought. You have this massive tumor, and the drugs are basically bouncing off the biggest part of it because those cells are all asleep.
And this leads to a clinical pearl that Katsung really emphasizes, which explains a procedure that I think often confuses people: debulking surgery.
I have always found this counterintuitive. The surgeon goes in and says, look, I can't get it all, but I'll take out 90%. Why bother if you're leaving 10% behind? Won't it just grow back?
It's not just about making the tumor smaller. It is about waking it up.
Blah.
By removing the bulk of the tumor, you free up resources. The remaining 10% of cells suddenly have access to blood and oxygen and nutrients again. They look around, they see all this new space, and they exit that safe, resting G0 phase.
They re-enter the cell cycle.
And they start dividing again. You force them out of hiding.
You make them vulnerable.
Exactly. You push them from the safe, dormant phase back into the vulnerable, proliferative phase. Then and only then do you hit them with the chemotherapy. You basically make the cancer aggressive again so you can kill it.
That is some 4D chess right there. But it also brings us to the absolute limit of the old world. We are still relying on the cell dividing in order to kill it. And this is where Goodman and Gilman introduces the paradigm shift, the concept of oncogene addiction.
This is the philosophical leap. In the old way, we asked, is it moving? Is it dividing? In the new way, we ask, what is holding it up? What is driving it?
I really love the architectural metaphor they use here.
It's the best way to visualize it. Think of a normal, healthy cell, like a Greek Parthenon. It's held up by, say, 50 different pillars. These pillars are all different signaling pathways, redundant systems that keep the cell alive.
So if you knock out one pillar,
the roof stays up. There are 49 others taking the load. It's safe. It's stable. It's what we call evolutionary redundancy.
Okay, but a cancer cell is different.
A cancer cell is completely different. It's often driven by a mutation in just one specific pathway. So it ignores the other 49 pillars. It builds this massive, unstable skyscraper on top of that one single mutated pillar.
So it looks big and scary, but structurally, it's actually incredibly fragile.
It is addicted to that one driver signal.
Yeah.
If we can identify that single pillar, that one driver mutation, and we can knock it out,
The whole skyscraper just collapses.
the whole thing comes down.
And here's the key distinction for me. Does the cell have to be dividing for this to work?
No. And that is the beauty of it. That's the revolution. Even if that cancer cell is sitting quietly in G0, if you cut off the survival signal that it's addicted to, it triggers apoptosis. It commits suicide.
So we aren't waiting for them to come out of the bunker anymore. We are cutting the air supply to the bunker.
Precisely. That is the promise, the core idea of targeted therapy. We are trading the kinetics of cell division for the molecular biology of survival.
Okay, so we know we want to blow up that specific pillar. Now we need the explosives. And this brings us to section 2, the arsenal. Goodman and Gilman draws a really hard line in the sand here between two types of drugs,
The big ones and the small ones.
the monoclonal antibodies and the small molecule inhibitors, or as I like to call them, the MABs and the IBs.
The MABs and the IBs. It sounds a little simplistic, but the physics of size dictates absolutely everything here. How they work, how you take them, what they do to your body, it's all about size.
Let's start with the giants then, the MABs.
Monoclonal antibodies. These are proteins. Specifically, they are immunoglobulins, usually a type called IgG. In the molecular world, these are aircraft carriers. They're massive, about 150 kilodaltons if you want the number.
Because they're so massive.
They cannot get inside the cell. The cell membrane is like a velvet rope at a nightclub, and these antibodies are definitely not on the list. They are way too big to pass through.
So they are strictly an external force.
Correct. They only work on targets that are on the outside surface of the cell, or maybe on proteins that are just floating around in the blood. They are the bouncers at the door.
So how do they actually stop the cancer if they have to stay outside?
Well, Goodman and Gilman outlines three main mechanisms. The first one is called ligand blockade. So imagine the growth signal is a baseball being thrown at the cell. The antibody just, it catches the ball midair.
So it never hits the catcher's mitt, no signal.
Exactly. The second way is receptor blockade. The antibody goes and it sits in the catcher's mitt. It physically jams the lock so the key can't get in.
And the third way.
This is the real superpower of the antibody, immune recruitment. Because it is an antibody, it has a tail section, the Fc region, and this tail acts like a big, bright flag. When an antibody binds to a cancer cell, it starts waving that flag.
And who is it waving at?
It's waving at the immune system, at natural killer cells, at macrophages. It's basically yelling, hey, over here, come eat this thing. We call this ADCC, antibody-dependent cellular cytotoxicity, and small molecules generally can't do this.
Now, there's a secret code in the names of these drugs that I think is fascinating. Goodman and Gilman has a great text box on this. The suffix is always de mab, but the letters before it tell a whole history lesson.
Yes, it perfectly tracks the evolution of our technology. In the early days, we made these antibodies in mice.
A full mouse protein.
That's right. They had the infix O, like in muramonab. But the human body, it hated them. It recognized this mouse protein as foreign, and it would attack the drug itself.
We call it HAMA, right? Human anti-mouse antibody.
Exactly.
Yeah.
And the drug would stop working, or even worse, the patient could go into anaphylaxis. So it was a real problem.
So the scientists had to disguise the mouse.
They started to replace parts of the mouse protein with human protein. And this is what gives us that naming convention. If you see a drug name with basica in the middle, like cetuximab, it's a chimeric antibody.
Like the chimera from mythology. Part human, part mouse.
Right. It's about 65% human, 35% mouse. It's better, but there's still some risk of a reaction. Then they got even better. They kept only the tiny binding tips from the mouse and made the entire rest of the structure human. These have a zoo in the name, like trastuzumab.
Humanized.
Humanized. And finally, we have the modern era. We have fully human antibodies, which are made in these transgenic mice that have been given human immune systems. These have a U in the name, like panitumumab.
So if I see that I know it's fully human, and I can guess I'm less likely to have a major allergic reaction than with a...
In general, yes. Infusion reactions can still happen for other reasons, but the risk of that specific anti-drug antibody response is much, much lower.
And speaking of infusions, let's talk logistics. If I'm on a MAB, I'm not taking a pill with my morning coffee.
No, absolutely not. If you swallowed an antibody, your stomach acid would just digest it like a piece of steak with a protein. So it has to be given intravenously. But the good news is the half-life.
How long does it actually last in the body?
For weeks. The kidneys can't filter these huge proteins out, and the body actually has a special recycling mechanism for them. So you might only have to go to the infusion center once every 2 or even 3 weeks.
Okay, let's contrast all of that with the IBs, the small molecules.
Those are the polar opposites in every single way. These are tiny synthetic organic chemicals, and because they're small, they're like ghosts. They can slip right through the cell membrane like it isn't even there.
So they do their work inside.
Deep inside,
Yeah.
in the engine room. Most of these are what we call tyrosine kinase inhibitors, or TKIs.
We see the word kinase everywhere in this chapter. What is a kinase, really, at its most basic level?
The simplest definition is, a kinase is an on-off switch. It takes a phosphate group from ATP, which is the cell's fuel, and it sticks that phosphate onto another protein. That act of phosphorylation is what turns the protein on.
So the kinase has to have ATP to work.
Yes, and the small molecule inhibitor is a master of disguise. It is shaped to look almost exactly like ATP.
It's a counterfeit key.
It's a counterfeit key that slides into the binding pocket of the kinase, the little spot that's reserved for ATP, and it just sits there. So when the real ATP comes along and tries to get in, the seat is already taken.
No ATP, no energy transfer, no
Yeah.
signal. The engine just stalls.
Precisely. This is classic competitive inhibition.
And for the patient, this means what?
It means a pill, oral administration. It's incredibly convenient. But, and this is but unlike the antibodies, these drugs have to be processed by the liver,
The cytochrome P450 system.
the famous CYPs. And this is a huge safety red flag that Goodman and Gilman waves repeatedly. Since these drugs are metabolized by the liver, they interact with basically everything else the liver is trying to process.
So if I'm taking a TKI, and I also take, I don't know, an antifungal medication.
Like ketoconazole,
Yeah.
that blocks the CYP enzymes. So suddenly the cancer drug isn't being broken down. The levels in your blood can spike to toxic ranges.
And what if I take something like St. John's wort?
That's an inducer. It revs up the enzymes. So the liver starts chewing up the cancer drug way too fast. Your drug levels plummet, and the cancer can start growing again. You have to be incredibly careful with the patient's entire medication list.
You also mentioned that the IBs can be dirtier.
Yeah, that's lab slang for less selective. An antibody is usually hyperspecific. It binds to one target. But the ATP pocket in one kinase looks an awful lot like the ATP pocket in a different kinase.
They all use the same kind of fuel.
Exactly. So if you design a drug to block kinase A, it might accidentally block kinase B and kinase C as well.
Is that a bad thing?
Sometimes it's bad. That's what causes a lot of the off-target side effects. But sometimes it's good. We have drugs we call multi-kinase inhibitors. A drug like sunitinib can hit the tumor's blood supply and its growth signals at the same time. It's a bit like a widespread shotgun blast, but just inside the cell.
So to summarize, MABs are big, IV specific, and work outside the cell. IBs are small, oral, can be dirty, and work inside the cell.
You've got the whole arsenal down. That's the core distinction.
All right, let's deploy it. Section 3, the prototype. We are going to look at the EGFR pathway. This seems to be the Model T of targeted therapy education.
It is. It really is. If you can understand EGFR, you understand the fundamental logic of the entire field. It's the perfect case study of pathway addiction, intervention, and then ultimately resistance.
So set the scene for us. Normal physiology. What is EGFR doing in my body right now?
In your skin and in your lung lining, EGFR, the epidermal growth factor receptor, is a sensor. It sits on the cell membrane, and it's just waiting for a signal to repair or to grow.
And the signal arrives.
A ligand, like EGF itself, floats by and binds to the receptor. The receptor then dimerizes, it finds a partner and pairs up. And that physical pairing is what turns on the tyrosine kinase that's on the inside part of the receptor.
The switch flips.
The switch flips, and it triggers a relay race inside the cell. We call it the M kinase pathway. The baton gets passed from one protein to the next. RAS passes to RAF, which passes to ME, which passes to ARC.
Ras, Raf, Mech, Erk. It's got a rhythm to it.
It does. And then ERK, the last runner, runs into the nucleus and tells the DNA, time to divide.
Okay, that's normal. So what happens in, for example, non-small cell lung cancer?
In many of these patients, there's a specific mutation in the EGFR gene itself. Goodman and Gilman specifies the exon 19 deletion or the L858R point mutation.
And what does that mutation actually do to the machine?
It jams the kinase in the on position. It doesn't need the ligand anymore. It doesn't need to dimerize. It just sits there and screams divide 24 hours a day, 7 days a week.
And the cell is addicted to that screening.
Completely addicted. So we attack. Now, we could use an antibody like cetuximab to try and block the outside.
But wait, if the mutation is inside the cell, the part that's locking the switch on, does blocking the outside really help?
That is a very, very sharp question. And in this specific lung cancer scenario, no, not really. The problem is internal. Blocking the front door doesn't stop the party that's already raging in the kitchen. So the heavy lifting here is done by the small molecules, the TKIs.
So drugs like erlotinib or gefitinib.
Exactly. They slip inside the cell, they find that hyperactive kinase, and they jam themselves into the ATT pocket. They silence the scream.
And what's the effect for the patient?
It can be miraculous. I mean, we call it the Lazarus effect. You can see patients who are bedbound on oxygen, just riddled with tumors, and their scans can clear up in a matter of weeks. It's one of the most gratifying things to see in all of medicine.
There's a catch. There's always a catch. Let's talk about this idea of toxicity as a biomarker. You mentioned the rash.
The acneiform rash. It looks like very bad acne, typically on the face, chest, and back.
Usually we think of side effects as something we want to avoid, but in this case, the doctors,
Yeah.
they actually like to see it.
It's a grim reassurance, I guess you could say. Remember, EGFR stands for epidermal growth factor receptor. Your normal skin absolutely needs it to stay healthy. So if you are effectively blocking EGFR in the tumor, you are, by definition, also blocking it in the skin.
So if I get the rash, I know the drug is actually working, it's hitting the target.
Exactly. In fact, studies have shown a clear correlation. Patients who develop the rash often have better survival outcomes. It's what we call on-target toxicity. It tells you the dose is sufficient to do its job.
Now, I want to talk about a specific failure mode that's mentioned in the text, the KRAS mutation. We talked about that relay race, RAS, MEK.
Right. KRAS is the runner right after the receptor, the first handoff.
What happens if KRAS itself is mutated?
If KRAS is mutated, it's stuck in the on position. It's just running with the baton, whether it got the handoff from the receptor or not.
So if I have a patient with, say, colon cancer, and I give them an EGFR antibody like Stuximab,
It is completely useless because the signal is starting below the blockage. It's like locking the front door when you know the burglar is already inside and running around the house.
and this is why you must test.
You must test for KRAS mutations before using these drugs. If the mutation is there, you save the patient the toxicity and the enormous cost because the drug simply will not work.
That's the definition of precision medicine, knowing when not to treat.
That's a huge part of it, yes.
Okay, now let's talk about the inevitable failure of the drugs that do work, at least initially. Resistance. You said a drug like erlotinib works dramatically, but not forever.
No, not forever. On average, the first generation drugs like that work for about 10 to 12 months, and then inevitably the tumor starts growing again.
What happened? Did it just kick the addiction?
No,
Ugh.
it changed the lock. This is the famous T790M mutation.
Break that down for me. T790M.
So it refers to the amino acid at position 790 in the protein chain. The normal threonine, which is a T, gets swapped for a methionine, an M.
Is methionine bigger?
Much bigger. It's a bulky amino acid, so it sticks out right into the ATP binding pocket.
So the drug erlotinib tries to get in.
And it physically can't fit anymore. It's like trying to put your house key in a lock that someone has stuffed full of gum. We call this steric hindrance.
But the natural ATP can still fit.
Yes. ATP is small and flexible enough that it can still squeeze past the methionine, so the engine turns back on, but our drug is locked out.
Game over.
It used to be, but not anymore. This is the arms race. The chemists looked at the new shape of that T790M pocket, and they designed a new molecule, a third-generation inhibitor called osimertinib.
Let me guess. It's shaped to fit perfectly around that bulky methionine.
It fits the new mutated pocket perfectly. It restores the blockade. In fact, osimertinib is now the standard of care right from the beginning because it handles this resistance mutation so incredibly well.
It's just incredible. It's molecular warfare. Move, counter-move, counter-counter-move.
That's the game.
All right, let's zoom out a bit. We've been talking about the tumor cell itself, but Section 4 takes us to the neighborhood, to the tumor's environment, specifically the plumbing.
Angiogenesis. And this story really starts with a scientist named Judah Folkman back in the 1970s. He proposed this radical idea that tumors are completely dependent on their blood supply. He said a tumor cannot grow larger than 1 or 2 millimeters, about the size of a BB pellet, without recruiting its own blood vessels.
It needs oxygen, it needs nutrients.
It needs supply lines. So the tumor secretes a powerful signal, VEGF, that's vascular endothelial growth factor. It's basically yelling to all the nearby blood vessels, hey, build a highway over here, I need supplies.
So the strategy becomes silence the VEGF.
And Ketsong and Goodman and Gilman list a few key weapons here. The most famous one is probably bevacizumab, which is also known as Avastin.
There's a Maybab, an antibody.
It is, but interestingly, it doesn't bind to a cell. It binds to the VEGF protein itself, while it is just floating around in the bloodstream.
So it's a sponge.
It's a molecular sponge. It just soaks up the signal before it can ever reach the receptors on the blood vessel cells.
Then you have a drug called aflibercept. I love the name because it just sounds so high-tech.
It is very high-tech. It's what we call a VEGF trap. The engineers who designed it, they basically cut the catcher's mitts off of the VEGF receptors and glued them onto an antibody tail.
A decoy receptor.
A super decoy. It binds to VEGF much, much tighter than the body's own natural receptors do. It's extremely effective.
And ramucirumab.
That one takes the other approach. It blocks the receptor itself, VEGFR2, on the blood vessel cells. So if bevacizumab is catching the ball, ramucirumab is jamming the mitt.
The result is the same either way. The
Yeah.
blood vessels regress, the tumor starts to starve, but blood vessels are pretty important for other things in the body.
And this is where the so what of toxicity becomes both fascinating and incredibly dangerous. Since these drugs work on blood vessels everywhere, not just in the tumor, we see these systemic body-wide effects.
Hypertension is the big one,
It's
Ross.
very common. VEGF actually helps regulate your normal blood pressure by signaling vessels to relax via nitric oxide. If you block VEGF, you block that nitric oxide signal. The vessels constrict, and the pressure shoots up.
And wound healing.
This is a critical board exam question and a real-life disaster if you miss it. VEGF is the primary signal your body uses to heal a cut. So if a surgeon operates on a patient who is on bevacizumab,
The one don't close.
it can dehiss. You can just split right open. You have to stop these drugs for weeks before any planned surgery.
And there's this weird, surprising crossover in the reading. We're talking about lung cancer, colon cancer, kidney cancer, and then suddenly, the eye.
Yes, the ophthalmic connection. It's a disease called wet macular degeneration.
Which is the leading cause of blindness in the elderly.
And the pathology of the disease is it's angiogenesis. It's leaky, overgrown blood vessels in the retina that destroy a person's vision.
So they use cancer drugs for this.
They inject them directly into the eyeball. Bevacizumab, or a smaller fragment of it called ranibizumab, is injected right into the vitreous.
Wait, into the eye? With a needle? Into the eyeball?
Into the jelly of the eye, yes. It sounds awful, I know, but it saves sight. It dries up those leaky vessels and can restore vision.
Is the dose the same as for cancer?
Oh, no, not at all. It's a tiny, tiny fraction of the cancer dose, which is why we don't see the hypertension or the bowel perforation in these eye patients. The drug just stays in the eye. It's a perfect example of mechanism-based medicine. If you understand the pathway, VEGF, you can treat a lung tumor or a blind eye with the exact same logic.
That is just wild. Okay, let's move to section 5. This is the topic that has probably generated the most excitement and the most Nobel Prizes in the last decade. Immunotherapy.
Releasing the brakes.
Exactly. We're not targeting the tumor's addiction. We're not targeting its blood supply. We are hacking the patient's own immune system.
Specifically, we're targeting the T cells. And we're talking about the PD-1 pathway.
So walk us through this metaphor of the secret handshake.
Okay, imagine a T cell is a police officer and it's patrolling the body. It goes up to every cell and it asks for ID. If the cell is a normal, healthy citizen, it flashes a protein on its surface called PD-L1.
And the T cell has some kind of scanner.
The scanner is a receptor on the T cell called PD-1. When that scanner, PD-1, reads the ID, PD-L1, it sends a powerful negative signal to the T cell. It basically says, this is one of us, don't shoot, move along.
So it's a safety mechanism. It prevents autoimmune disease. It stops the cops from beating up the civilians.
Yeah. Exactly. But cancer cells are clever. They have learned to steal the ID. They express massive amounts of this PD-L1 protein on their surface.
Say the T cell comes along, it's ready to kill this mutated freak of a cell.
And it scans the ID, it gets that don't shoot signal, and it just walks away. The tumor hides in plain sight. This is called immune evasion.
So a drug like pembrolizumab or Keytruda, what does it do?
It is an antibody that binds to the PD-1 receptor on the T cell. It basically puts a piece of duct tape over the scanner.
So when the cancer cell tries to show its fake ID,
the scanner is blocked. No negative signal gets through. The T cell looks at the tumor, recognizes it as foreign, and it unleashes hell.
it's an incredible concept. But it doesn't work for everybody. How do we know who it's going to work for?
This is where biomarkers are absolutely critical. And Goodman and Gilman highlights two. MSIH, which is microsatellite instability high, or MMR deficiency, which is mismatch repair deficiency.
Okay, those are mouthfuls. Can you simplify that for us?
Think of it as a broken spell checker. Normal cells have enzymes that go through and fix typos in the DNA. These particular tumors have lost that ability.
So they have typos everywhere.
Thousands of them. And because they have so many DNA mutations, they make all these weird mutated proteins. We call them neoantigens.
They just look ugly.
To the immune system, they look like aliens. A tumor with high microsatellite instability and MSI high tumor is what we call hot. The T cells are already swarming around it. They're trying to attack, but they're being held back by that PD-1 handshake.
So if you cut the handshake with pembrolizumab,
the response is explosive. The immune system already knows exactly who to kill. You just finally gave it permission to do so.
and this led to a truly historic FDA approval, didn't it?
It did. The first tissue-agnostic approval in history. The FDA approved pembrolizumab for any solid tumor with MSIH.
It didn't say colon cancer or stomach cancer.
No. It said, if you have this specific genetic feature, you can get the drug. It doesn't matter where in the body the tumor is. That is the paradigm shift. We're not treating the organ anymore. We are treating the genetic mistake.
But of course, the toxicity, if we're uncuffing the police.
They might arrest some innocent civilians. We see a whole host of autoimmune adverse events. Colitis is a big one. The immune system attacks the lining of the gut. Pneumonitis, it attacks the lungs. Thyroiditis.
It's the complete opposite of chemotherapy. Chemo suppresses the immune system, you get neutropenia. Immunotherapy can rev it up too high.
Exactly. And the treatment is quite ironic. If a patient gets severe colitis from a drug like pembrolizumab, you have to give them high-dose steroids to suppress their immune system. You have to dampen the very force you just unleashed in order to save the patient from their own T cells.
Let's do a quick lightning round for Section 6. There are a few other key pathways in the text that we just can't ignore because they really changed medical history.
Let's hit them. First up, proteasome inhibitors. The main drug here is bortezomib.
And this is used in multiple myeloma.
That's right. The mechanism is the trash compactor. The proteasome is the machine in the cell that recycles old, broken proteins. And myeloma cells are basically antibody factories. They make tons and tons of protein.
So they generate a lot of trash.
A huge amount of trash. So if you jam the trash compactor, the proteasome with bortezomib, all this toxic garbage just piles up inside the cell. The cell literally chokes on its own waste and dies. It's highly effective for plasma cells because they are so metabolically active.
Okay, next. BCR-ABL.
The grandfather of them all. Imatinib or Gleevec. This is for CML chronic myeloid leukemia.
And CML is caused by the Philadelphia chromosome.
Right, a swap of genetic material between chromosome 9 and chromosome 22. It creates this Frankenstein fusion protein, PCR-ABL, and it's a kinase that is just constantly on.
And imatinib was the first drug to really turn it off.
It turned a fatal leukemia into a manageable chronic disease. Patients take a pill a day and can live normal lifespans. It was the proof of concept that started this entire revolution. It proved you could drug a kinase successfully.
And lastly, HER2.
Trastuzumab or Herceptin, this is for breast cancer. About 25% of breast cancers overexpress the HER2 receptor.
And the big toxicity warning here.
The heart. HER2 signals are actually needed for the normal repair of cardiac muscle, so trastuzumab can cause heart failure. You have to monitor the patient's LVEF, their left ventricular ejection fraction, constantly. If it starts to drop, you have to stop the drug.
Okay, we surveyed the entire arsenal, but we have to end on the reality check. Section 7, the trap. Why isn't cancer cured yet?
Because cancer is evolution on fast forward. We already talked about gatekeeper mutations like T790M, the tumor changing the lock. But there are even more devious ways for it to escape.
Goodman and Gilman calls them bypass tracks.
It's a great term. Imagine you're driving down the highway, let's say that's the EGFR pathway, and you hit a roadblock, a big one. What do you do?
I get off and I take the service road.
Exactly. You block the EGFR pathway, so the tumor just amplifies the MYNIT gene, or it turns on the IGF-1R receptor. It finds a parallel pathway, a different road, to send the exact same survival signal to the nucleus.
Life finds a way.
Unfortunately for us, yes. This is pathway redundancy. The cell has backup generators. It has other options.
So what is the strategy? How do we possibly win this arms race?
Combinations. We learned this lesson from treating HIV and from treating tuberculosis. You rarely, if ever, cure a complex, evolving disease with just one drug. So we are starting to combine these targeted therapies. We try to block the highway and the service road at the same time.
Can you give us an example of that?
In melanoma, we often use a BRAF inhibitor like dabrafenib and a MEK inhibitor like trametinib together.
And BRAF and MEK. Those are right next to each other in that same relay race we talked about.
Exactly. You hit two consecutive steps in the same pathway. It's like setting up two roadblocks on the same highway, 1 mile apart. If the car somehow sneaks past the first one, the second one is there to catch it. And this delays the development of resistance significantly.
It buys time.
In oncology, time is the currency. We buy months, then we buy years, and we just hope that in that time, the next discovery, the next smart missile comes along.
This has been a massive download. Let's head to the outro and try to synthesize all of this.
If you zoom all the way out, you can really see the trajectory of the field. We started with Kitsung's log kill. It was brute force, it was managing bone marrow toxicity, and it was, hoping for the best.
And we moved to Goodman and Gilman's pathway addiction, which is about surgical strikes, molecular understanding, and biomarker-driven decisions.
And we traded the broad systemic toxicity of killing everything that's dividing for the new, very specific toxicities of the targets themselves. The rash from EGFR, the hypertension from VEGF, the autoimmunity from PD-1.
And here's the final provocative thought we want to leave you with.
Think about that tissue-agnostic approval again. For 100 years, medicine has been organized by anatomy. You're a lung doctor or a colon doctor. You go to the breast cancer clinic.
Right. The organ is what defines the disease.
But if the drugs are targeting pathways like EGFR or MSIH, regardless of what organ they're in, are we moving toward a future where anatomy is almost irrelevant, where you don't have lung cancer, you just have EGFR-mutated malignancy?
The molecular diagnosis becomes the only one that really matters.
It challenges the entire structure of how we practice medicine. I mean, are we ready for an oncology ward where the patients are grouped by their mutation, not by their organ of origin? It's a fascinating future to consider.
That is a huge thought to end on. Thank you for guiding us through the molecules and the mechanism.
My pleasure. It's been great.
And thank you, the listener. Your mission now, should you choose to accept it. Open Goodman and Gilman's chapter on pathway-targeted therapies. Look at those kinase pocket diagrams. Then open Katsung's chapter on cancer chemotherapy and look at the cell cycle charts.
The podcast is the map, but the book is the territory. Go and explore it.
We'll see you in the next deep dive.